So welcome, ladies and gentlemen, to our edition of Alliance for Science Live. And today we are going to discuss COVID-19 and Africa, myths, truths, and the way forward as countries start to open up. So those of us who have joined us through Zoom, thank you very much. Those of you listening in, watching in from Facebook, as always, send this link to someone, call someone and tell them this conversation is going to be exciting. And don't forget to send in your questions via Facebook. Let us know of any myths you have had in your community. The experts are here, they are going to dispel them, and they are also going to explain to us quite a number of the truth about COVID and how we should be dealing with it as Africans. So Christine Elong is our host today, and I would like to hand over to you, Christine.
Thank you very much, Patricia. It's an honor for me to be with the team today to discuss today's topic, that is on COVID-19, the myths and truth, and the easing down of lockdowns by African governments. What is a myth, you may be asking yourself? A myth is a widely held but false belief or idea that people carry on and that affects our decisions and the way we do life. And with us, we have two distinguished panelists. One is Dr. Mercy Korir from Nairobi, Kenya. She is a medical doctor with a degree in medicine and surgery and a master's degree in communications, specifically development communications. She is the lead group editor of Science and Health with the Nation Media Group in Kenya, Nairobi, Kenya. She's very passionate about health and rights of people, access to health and things regarding having access to health and good lifestyle. She's an accomplished medical journalist and has her own TV show in Nairobi, Kenya. You're very welcome, Dr. Mercy.
Thank you.
And with her is Dr. Winstons Muhwezi from Uganda. He's an associate professor from Makerere University in behavioral sciences and mental health. He has a degree in social work and social administration. He also has a master's in health promotion from Norway and a PhD in medical science, specifically on behavioral science and mental health. He is very passionate about mental health and is an external examiner with the University of Nairobi and Moi University in Kenya. And in Uganda, he's an external examiner with Bishop Stewart and Nkumba University. And also in Sweden, he is an external examiner with Karolinska Institute and also with Stellenkop in South Africa. You're very welcome, Dr. Muhwezi.
Thank you.
Yes.
So maybe like just before we proceed, Christine, if you could please turn and directly face into your camera. You're looking off. We want people to see.
Sorry.
Okay. Yes,
is that better?
Yes. So we can start maybe with Dr. Winston. Dr. Winston, your credentials are very impressive. So please tell us, what have you had in the community as you're dealing with, as Uganda is dealing with COVID-19? What are some of the myths that you have had?
Thank you very much, Patricia, for giving me the opportunity to start by saying something about what I've heard, or some of the myths that I've heard, but also to perhaps add emphasis and explanation about myself. Actually, before I joined in, I was in another meeting, which is scientific advisory committee meeting to the Minister of Health on COVID-19, where I'm one of the members that advise our Minister of Health on how to approach the COVID-19 response. And I've also been part and parcel of different initiatives to deal with the viral hemorrhagic fevers from the psychosocial perspective. That's a particular bit of me, and I've picked quite a number of things along the way in my participation in these different fora. Now, what have I heard about myth? There is a lot of myth going on that I've come across, so many. Perhaps I can just mention a few. I know that one of the myths circulating around which I've come across on social media is that because of their dark skin color, the Africans can only get a mild form of COVID-19, for example. So that meaning that our skin color may be protective. That perhaps because of the hot weather, which is quite common in much of Africa, will be protected against the COVID-19. That COVID-19 infection cannot be transmitted in areas with very hot and humid climates, and therefore that's why it's doing havoc in the temperate regions, and for us in tropics, maybe we could be safe. Others think that drinking lots of hot drinks can stop COVID-19. Dawa tea, for example, which is common in Kenya. I first met it in Kenya, but it's common in Uganda as well these days. It's that it's helpful. Some people say when you eat garlic and turmeric or lemon and other foods commonly used as home remedies for flu are enough to help prevent COVID-19. Others would talk of, so many myths, talk of regularly raising with water and saline water, saline to help in prevention, drinking warm water and getting enough sunlight to be effective, spraying alcohol or chlorine all over your body, that this can kill the germ. Others think that when you take alcohol can protect you against COVID-19. I've come across others which are weird. For example, using cow dung and cow urine as a cure for COVID-19. Others actually go religious and propose that religious chants can protect one from getting infected by COVID-19, or even through some religious ceremonies of laying on of hands or rebuking the devil, you can take away the virus from the body. Some think even the virus can be transmitted through a mosquito bite. So there are so many myths. That's what I can say for now, but there is a lot of mythology that's associated with this very dangerous and very scary disease. That's where I can stop for now. Thank you.
Christine?
Thank you very much, Dr. Muhwezi. I would also like to hear from Dr. Mercy. What other myths have you heard regarding COVID-19 in Kenya?
Okay, I think Dr. Muhwezi has covered quite a number, because you can imagine we live in the same continent, in the same region, more or less. The same myths have been propagated that have been the same for all of us across. And I remember, I think at the height of the pandemic in China, in Europe, and going to America, we saw very few, if any, Black people getting the virus. So obviously the conversation was that, this thing is only going to affect white people, and we, because of our Black skin, probably because of our genetics, because of race, we are not going to get affected by the coronavirus. But I think over time we've seen that actually that has been very different, and we've seen from the US where it has actually brought out the racial inequalities, where we have Blacks in some communities really bearing the brunt of the coronavirus. The other thing, just to add on Dr. Muhwezi, I don't know about Uganda, but here in Kenya, the joke is that the lemons now are the same price as apples. because there's been a whole craze about, taking lemon improves your immunity. So there's been a whole craze. People are looking for lemons left, right, and center. People are looking for ginger, for garlic. So actually, these things have actually gone up in price. Anyone who was selling them before is in for a kill because people are making these concoctions. I think it's what you are calling what did you call it, Dr. Muhwezi? Chai something. We have lots of concoctions also here in Kenya. They are called dawa, where you mix the lemon, the honey, and the ginger, and you take that, and people are actually taking it religiously. The other thing that we've seen is when Madagascar talked of COVID-19 organic, we actually looked for that plant here in Kenya so that we find out if Madagascar is saying this particular plant is treatment or will help with COVID-19. If we have it here in Kenya, then we are going to also use it for the same treatment. So I think the myths that have been around here initially were about getting infection. The other one was on the treatment aspect of it and how to cope with it. So I think we are more or less around the same. And I actually seen even people, professors, learned people, when they get diagnosed with COVID, because there's no treatment per se for it, they've actually been taking these concoctions and they believe that is actually what is curing them or making them not die or not get severe illness from COVID-19. So being in the same continent, I think we are seeing the same myths about the pandemic.
Okay, thank you very much. And I've also had people say that young people are immune to the COVID-19 COVID-19 virus. And also the thought that, yes, doctor?
No, I'm saying
that,
yes.
that belief that COVID-19, yes, and the belief that COVID-19 is a hoax. It was created by some people who want to control the world, control the economy of the world by selling a vaccine that they have developed. I don't know if you've heard that as well. Dr. Muhwezi, have you heard that?
Yes.
It is extremely pervasive. That's very common. It's one of the biggest challenges to adherence to the prevention guidelines. People think this is a hoax, this is a ploy. In Uganda, people are saying, oh, this is a ploy for some of the usual suspects to steal money and do their own thing.
Yes.
So
yes.
Yeah, it's quite pervasive. It's quite pervasive.
Quite pervasive.
Yeah.
And Dr. Mercy, oh yes, please, Patricia, do.
Yes, so
yes, Patricia, go ahead.
The myths that you've talked about, I would like to understand if people believe that COVID-19 is a hoax and it doesn't exist, what do you as people in this field, medical doctors, think? Is it really a hoax? Because in Uganda, we have seen a few deaths being reported recently, and people are coming out to say those people did not die of COVID-19. They died of some other things. And when you talk about, especially Dr. Mercy, I would like to hear from you. When you talk about lemon and ginger and all these dawa teas that people are drinking, is it really a myth? Aren't these immune boosters, don't they have high levels of vitamin C? And isn't there a bit of truth in some of these things that we are hearing? So maybe Dr. Winston, you can go first on the hoax issue.
Thank you very much. As of now, these are statements, these are sentiments that people are pushing around. But in science, we know that science progresses through setting hypotheses and up to prove otherwise that these hypotheses are valid or not valid. So as of now, we may call them hypotheses. I mean, we may call them myths, but these are very good hypotheses. As you and me know, COVID-19 caused by coronavirus is a new disease. It has no treatment the world over. Whatever is provided is supportive therapy to help the body to fight. So all these myths that we have listed are hypothetical. there is a lot of research going on in the world over trying for different lines of hypothesizing. And down the road, hopefully down the road, we may come to prove that some of these work in a certain way, or some of these are dangerous in a certain way, or some of the practices, behaviors are actually necessary and they should be adopted or not. We are dealing with a very slippery situation here, and there are no hard and soft facts here. It's a world we are groping in the dark. It's a world of much unknown, especially when it comes to therapy, to treatment. As far as the science, as far as the transmission, those seem to have been settled. But therapy, it's still very fluid. That's what I can say.
Okay. Thank you, Dr. Muhwezi. Yes.
Just add on to Dr. Muhwezi, I think we usually say where there is smoke, there is fire. So there is some truth. Yes, we know that something like lemon, garlic, ginger have an effect on the immune system. However, they are not treatments. But you see, people are taking them to treat themselves when they have gotten infected with the virus. So there is, some of these things are laced with some bit of truth or some bit of something that may hint onto something. But for the reason that people are taking them, let's say you're taking lemon to treat yourself because you have COVID, obviously it's not going to work as treatment. So actually, like for me now being in media, what I do is just to provide people with information, what is right, what is not right, what is correct, what is incorrect, so that they can make an informed decision on, you know, on the choices that they are making, so that they know what is harmful to them and what is likely to be beneficial. And I'll take an example of when we had hydroxychloroquine. At the time, it was said to, you know, provide treatment. But when you looked at the scientific paper that was published saying it is treatment, it only had 20 patients. That's not a big enough sample for you to confidently come out and say this is treatment for the disease. So as medics and as journalists, it was now our responsibility to come out and say, this is the information that was published. This is what hydroxychloroquine is normally used for. This is what these people found out. But because the study sample is less or is small, we cannot conclusively say it is treatment. So now we come in as medics, as journalists, to now dispel and give people the right information so that they can make the right decisions.
Thank you very much, Dr. Mercy. Just a little more discussion on this. Dr. Muhwezi, as a behavioral scientist and expert in that, what causes people to create myths? What leads to people creating a story or a myth and it spread wide and far and people actually believe in it so strongly? What leads people to create myths?
I think throughout history, human beings have suffered or have encountered challenges, myriad of challenges in all aspects of life. And human beings have been threatened by these challenges, health challenges. We know we had the more recent, I think, recorded one was the Spanish flu, which we read about. But there have been other challenges. Traditionally, I know that in some communities in Uganda, there was smallpox even before the Europeans came here. But people were able to wade through this. Some passed away, certainly, many people died. So what I'm trying to say is that human beings are very creative. They are thinking creations of God. They postulate, they try out so many things. So I want to believe that there emergence and flourishing of this mythology about COVID-19 is really an attempt to look for, one, a logical explanation, but two, can work. It's trying to grope in the dark with the hope that one can see light at the end of the day. That's how these myths come up. Also, there is another angle to it, is that for those who are defiant and want to take this as a hoax, again, they're trying to look for explanations for their perspective. and give an alternative perspective to this. So ultimately, really, in conclusion, I can say that this myth will arise because of the human being's nature to think widely and either to help if the person is of a denying type, to justify his or her denial, or if the person is actually seeking out for help, to try out anything, maybe something will work out of that. That's what I can say.
Okay, thank you. Patricia, would you like to comment on that?
Not really. But I understand. I appreciate what Dr. Winston and Mercy have told us. That, you know, I like how Dr. Winston called this a hypothesis. People are trying to make sense out of this new scary disease. And Mercy also told us that usually where there is smoke, there is fire. So it's not that we are castigating people for trying to understand this, but we also just want to join our voices to Mercy, Winston, and the medical fraternity to tell people that, okay, you have had these myths, but this is the truth. That is not necessarily true. If you test positive, please take the medication that you're given. Do not treat yourself with lemon or ginger or whatever. But living healthy is good and we are for it. The more vitamin C in your body. So please continue taking that lemon and ginger. Live healthy, but also do what the medical experts are telling you to do in order to prevent this COVID-19.
Thank you, Patricia. And looking at the statistics of infections in Kenya and Uganda, Kenya right now is having over 31,000 infections, and Uganda is at 1,600 plus and counting. I don't know if Dr. Mercy, could this be that the Kenyans will have more myths that they are believing about concerning COVID-19 or not? But that said, I want to ask Dr. Mercy to help us unpack COVID-19. What exactly is COVID-19? What are the signs and symptoms of COVID-19? So that to help us understand what we are dealing with. Is it a hoax or is it actually a reality that we are facing this time? Over to you, Dr. Mercy.
I think what we have seen so far is that, yes, we have a virus that is within us as a global community. And this virus, now its scientific name is SARS-CoV-2, which is in the family of the coronaviruses. So we've had the coronaviruses for thousands of years. So this is nothing new. This is just a new strain that was found out in 2019 from traced to Wuhan, China. So this is something that has been there with us. That is, the coronaviruses are not new. We had the SARS epidemic in the early 2000s. We had MERS in the Middle East. We have the common cold, which is still caused by the coronaviruses. So these are viruses that have been there and they cause upper respiratory tract infections. And the issue with this coronavirus is that its symptoms are more or less the same as what you would get if you have flu or if you had the common cold. That's why initially we were telling people that, if you have flu-like symptoms, and these are a cough, and the cough from COVID-19 has been described as a deep, dry cough. People having fever, so something that has been very, very unique to this coronavirus is people have been spiking fever. So these are temperatures above 38. There are people who've recorded 40. So these are really high temperatures. It's a fever for many of the adults. People have had difficulty in breathing because the way it affects the lungs and the breathing system. So we've had people when they get difficulty in breathing. So for us here in Kenya, and I think most of the places, when you get difficulty in breathing, that's a telltale sign that you need extra care, you need care from a healthcare provider. So as the disease progressed along the way, other symptoms emerged where people got extreme fatigue, unexplained fatigue. Somebody has not been working out, for example, and all of a sudden they're just very tired, they cannot do anything else. We've had people complaining of inability to smell or to taste. where your food is now, you cannot tell really what you're eating or what you're tasting. If you pass by a dump site, if somebody is making food, you cannot smell that. So here it could be caused by any of the other upper respiratory tract infections, but it is indicative because we are in a situation where we have a virus within us in the community. It is indicative of the, of an infection by coronavirus SARS-CoV-2. So these are some of the symptoms that have been there. Of course, we've been seeing in Kenya that people are being tipped into diabetes, and so they present with other symptoms of high blood sugar, or when they take their their blood sugar, it's high, and they were previously not diabetic. So we've also been keen to check on people's sugar, especially people who are likely to have type 2 diabetes. So these are some of the common symptoms that we've been seeing around from the coronavirus. So unfortunately, as it is now, we do not have any treatment for it. We do not yet have a vaccine. I know functions that say they have a vaccine. We are yet to look at the data. We are yet to see the data on how they came up with this vaccine. What is this vaccine? What are the effects? There's a lot of information, a lot of data that one needs before you can conclusively say this is a cure or this is a vaccine. So these are ongoing studies. Initially, the WHO had set out what they call solidarity trials to check some of these medicines that have been said to work. Hydroxychloroquine was one of them. The antiretrovirals, lopinavir and ritonavir was also among those that were in the group to check if they work. Remdesivir, which had been tested for Ebola, was part of the medicines that are to be tested and checked. And obviously, clinical care of the patients to check. Dexamethasone, which is a commonly found steroid, especially in Africa, it's cheap, it's easily found, was also another of the medicines that was seen to work. And I know WHO actually okayed dexamethasone to manage the symptoms, because people who had been started on this dexamethasone did not progress to severe disease. So there's a lot that we can say about these COVID-19 infection, the COVID-19, but so far, yes, the other thing that I would say is that we think that people with existing conditions are affected more. In Kenya, our data has shown that 50% of the people that have died of COVID-19 from infections of the coronavirus have actually had diabetes and hypertension combined, or diabetes alone or hypertension alone. So here we are very keen on people with diabetes and hypertension because they are at higher risk of dying from this disease. Others we've seen are people with chronic lung infection, people who had TB previously. People with asthma have also suffered severe effects, or they've had severe symptoms from the disease. People who had cancer or HIV have actually, though the numbers are not as high as we expected, but there is our data of people who died from COVID-19. So people with existing conditions have had to take extra care, extra precautions, so that they do not get severe disease or they do not die eventually from COVID-19. So yeah, I've said a few, there's a lot that we can talk about when we start conversation.
Okay, that was very elaborate. Thank you very much, Dr. Mercy. I am curious, I want more information on when doctors say someone is asymptomatic, what do they mean? And how do they present if they have COVID-19?
So maybe Dr. Winston can answer, and then Christine, and then Mercy.
I am going to answer as a layman. I'm not a doctor. Christine can say the rest. But from my association and rubbing shoulders with the doctors whom I teach, but I also work with, asymptomatic patient would mean, it means that there is no laboratory confirmed result that a person has developed COVID-19, but the person actually can still transmit, although the testing in the lab has not yet picked the virus in this person. That's what I would as symptomatic. Really, the symptoms are not showing. The person has no flu. The person has no those basic conditions that symptoms and signs that my colleague has talked about. But that the virus is not even detectable, but it's there within that individual. That would be my understanding. But as I said, I'll hand over to my colleague, the medical doctor, to give my explanation. Thank you.
Thank you, Dr. Muhwezi. Mercy, we cannot see you. I think we have lost you. But as Mercy comes back, I would like to tell our participants via Zoom to please just type out your questions in the Q&A section or use the chat. I can see some people putting up their hands. Just type out your question and we shall read it out. So Dr. Mercy is connecting. Mercy, you can hear us?
Yes, sorry, I'm back. I think I had a bit of challenge with my Wi-Fi, but I think I'm back now. My apologies for that. I hope I had finished.
Yes, we had finished, and it's good to have you back. But Dr. Winston was responding to Christine's question of what does asymptomatic mean. So maybe if you can add to what he said, but this is what he said in case you missed it, that an asymptomatic person, it means that the lab did not pick up on the presence of the virus in their body, but they can still transmit. My question then would be, how can I transmit something that I don't have in the body? We shall discuss that later, but Mercy, please tell us what, from a medical perspective, what does asymptomatic mean?
Right. So our diagnosis of coronavirus is where we need to detect the presence of the DNA. In this case, this is an RNA virus, the presence of that RNA, which is, let's call it DNA, of the virus in the body. So what we are seeing, so now when somebody is sick, they either have symptoms of that disease or not. In this case, the symptoms that we are expecting from somebody who has coronavirus is fever, for example, a cough, or difficulty in breathing, and any of the other symptoms that I've said. So if somebody has those, they are symptomatic. When we say somebody is asymptomatic, it means they do not have symptoms, but we have detected the presence of the virus in their system, because we are taking a nasal swab, we are taking a throat swab. So it means when we went to swab, we found that they have DNA of this virus. So they have the virus, yes, but they do not have any of these symptoms. So in a nutshell, that's what asymptomatic means. So the controversy around this was whether they can transmit the virus or not. But so far, there has not been any convincing evidence that people who do not have the symptoms can transmit the virus. And how these people are found out is in routine contact tracing, because if I am diagnosed, if today I'm diagnosed with coronavirus, everyone I've come in contact with has to be tested to check if they've also gotten the disease. So that is how now people are found during contact tracing, for example, or we're seeing companies and organizations that are testing their workers to find out if they have the virus or not, so that they can do their own business planning and things like that. So you could be found to have the virus, yes, but you do not have any symptoms. So the controversy has been, can they transmit or not? So from my own thinking is, if you do not have a cough, you do not have a fever, you're not even sneezing, then it means, because these are cough droplets, you're not able to transmit them. You'll probably just remain with them. And that's why the whole thing about masking is important, because if you have the mask, anything that you have within you remains with you. So if at all you are to contaminate surfaces, if you are to, because when you have your mask, you are unlikely to touch your face or have your hand contaminated the way I'm doing. So even if I'm opening my window, I'm not contaminating those surfaces, because those high touch surface areas are the ones which now are likely to transmit. If I open the door, somebody else will come and touch the same door. If they forget and they touch their eyes, they get the infection from there. So that's why the whole point about wearing a mask at all times in public places is important. So I hope, Patricia, that's what we mean by asymptomatic. And it's actually quite interesting, because in Kenya, 93% of the people we have found to have the virus, which is 9 out of every 10 people, do not have any symptoms. So that's why we are seeing people are still going about their lives. And it could be the same with the rest of the African countries, because we have a younger population. They're likely to be more fit. Their immunity is likely to be better than if we had an older generation. And I think that's one of the explanations that have been there about why we are seeing what we are seeing. And also in Kenya, 50%, half of all the people that have been diagnosed with COVID-19 are actually less than 40 years of age. So you can see that that is actually a very young and energetic and robust group of people that even if they get the virus, chances are they're not likely to have symptoms or severe symptoms for that matter.
Thank you, Mercy. That clears quite a number of myths or misunderstandings that people have had. Yes.
Yes,
I wanted to seek for Mercy to explain more a bit. Can somebody who is asymptomatic today be symptomatic tomorrow?
Yes, definitely. You see, the incubation period between day 5 and day 7 of getting the infection.
We are losing Mercy, but as she reconnects, Christine, I would like to request you to keep an eye out on our Q&A section. Our participants are sending in quite a number of questions, and I think it's about time that we start responding to their questions. So as Dr. Mercy comes back, we can give some of these questions to Dr. Muhwezi.
Okay. There's a question from Mime. He says, Dr. Mercy, there's a popular myth here in Kenya that people get infected with the virus and healed naturally. How true is this from a medical perspective? That's to Dr. Mercy, but I think we have lost her. And then another question from Dennis. He says there are two overlapping aspects about COVID-19 in the community. One is that COVID-19 is being real, which is the truth, and another group is calling it a hoax. So the question is it the limited understanding in the difference between COVID-19 and the common cold? Because we need to have strategic responses. And the second question to that is, given that this is a novel virus, to what extent have the technical folks independently and collaboratively documented about its morbidity, I think. And then the third one is, we all know that the first international restrictive measures were many, but I want to pick on one measure, and that is the travel restrictions. How effective are travel restrictions and quarantines? Has there been any documented evidence on this? But most of these are to Dr. Mercy.
No, if Dr. Muhwezi can answer, even that question is not directed to him, he can pick whatever and answer. But maybe you can give them just one question at a time so that they don't forget.
At a time.
Yes.
So the one for Dr. Mercy, I think we shall leave that on hold. Dr. Muhwezi, there's a question about infected people getting healed naturally. The person is asking, how true is this from a medical perspective? One test gets infected with the COVID-19 virus, but somehow they get healed naturally. How true is this from a medical perspective? That's the question.
Thank you very much, Christine. Now, from my interaction with the scientists from the laboratory and from reading literature. That is a bit difficult to determine. You wouldn't know that somebody got the COVID-19 and healed naturally. You wouldn't know unless you do correct blood samples and test for antibodies, which would be indicative of somebody having been with the virus, and therefore you would say that this person has antibodies that are triggered by COVID-19 infection, and this person is now well. Then you would say, person fell sick. I mean, the person contracted the virus, the body cleared it, but the body will leave those footsteps that we can, in a scientific way, that we call antibodies. Short of that, which I think in many African countries that has not been done, to do community-wide studies to look for antibodies, the prevalence of antibodies associated with this virus is very difficult to tell. Of course, it's a common thinking, a common part of the myth that many people have already had this COVID-19 and recovered from it, just through verbal autopsy. But we need to prove it scientifically, and studies, I don't think we've seen them here in our setting in Africa.
Okay, thank you.
Thank you very much, Dr. Muhwezi.
We have quite a number of questions, so I would like to ask our panelists to be brief as we respond, because we also want to, our participants have shown immense interest, so that we answer as many questions as possible. And just a reminder to all participants, please don't raise your hand, just send your question through chat or the Q&A section. Over to you, Christine.
Thank you very much, Patricia. Dr. Massey is back on. Dr. Massey, there's a comment. Someone is saying there are two overlapping aspects about COVID-19 in the community. One group is saying believes that COVID-19 is real, and the other believe that it's a hoax. So the person is saying, from this, is it the limited understanding of the difference between COVID-19 and the common cold? Is this why people are having different? Some believe it's a hoax, some believe it's real. He's trying to relate it to the common cold. Is it because of the limited understanding of the difference between COVID-19 and the common cold? Because we need to have strategic responses to this.
I would look at it in two ways. And the first one, I think Dr. Muhwezi would be best placed to confirm if it's true. But the human psyche is such a way that if you have not seen something for yourself, or if you do not know somebody who's had it, then it remains a mystery. So if your own personal experience is that you've not seen somebody with COVID-19, or you do not know close to you within your proximity somebody with the disease, then you would probably think that it is not true. So that is one of the ways I would explain it. The second is that the way we have seen the virus, it could be any other upper respiratory tract infection. I mean, we've talked about fever, we've talked about a cough, we've talked about difficulty in breathing. If, for example, you get a running nose, as in all these symptoms that you would get when you have a flu or you have a common cold is more or less the same that you would get when you have COVID-19. When you have a flu, really, you don't even get hospitalized. You probably take the dawas or the honey concoctions, you'll hydrate, you'll keep, you'll do something, then your body will get over the difficult phase, you'll be okay and you'll go back. So when you relate it with what you are used to, and then you're told this very lethal disease that has caused deaths is the same, and what you're seeing is different, then you may think that probably that is an exaggeration. So I'd look at it from those two particular aspects.
Thank you very much. And the next question, still in that direction, the person is saying, given that this is a novel virus, To what extent have the technical folks independently or collaboratively documented about its morbidity? He wants to know about the level of documentation regarding fatalities from COVID-19.
I think every country is actually keen on documenting the number of people that have died from it. And if you look at the data, the constant thing about the data is how many cases have you confirmed, how many cases are recovered, how many are critically ill, how many have died, as a common, indicator for all the countries that are reporting their COVID-19 situation. So yes, countries are recording. Some countries, like Italy, have gone to an extent of giving you the age demographics, the different demographics that have been affected, what are the pre-existing conditions, and now studies are moving further to find out the duration of the critical illness or the duration between getting sick and dying. So there are many studies that are looking at this particular disease because, as I said quite rightly, it's a novel virus. We do not know much about it. We are still trying to find out. So people are trying to look at different facets, different angles of the virus so that we can try and understand as much as possible what this is, so that we are able to know how to treat it, because that is the ultimate goal, or how to get a vaccine. People have also gone to the extent of doing the genomic sequencing to know the genetic pattern of the virus, where, like, for example, in Kenya, the dominant strain of the virus has been traced to Europe. So people are actually going to that extent so that you're able to know what does this virus do. People are going to the extent of knowing the mutation that is happening, because they are viruses and they are prone to mutations. So people are going to that extent to know the mutations, to know, so is this more lethal than the other one? Is it getting weaker? So there are lots and lots of studies. And I keep telling people, we are only 7.5 months, 7 months, almost 8 months with the virus. There's a lot more that we didn't know. When we had HIV around, I remember with HIV, I was still starting my medical school, and we were still not very sure about mother-to-child transmission of the virus. But right now we know that mother-to-child transmission of HIV is actually one of the key transmission points, and that's why we have put in a lot of measures to prevent mother-to-child transmission. But that took some years before people did studies and were able to find out. So it's the same thing with this COVID-19, SARS-CoV-2. There are still many more studies that are needed for us to fully understand and know what exactly we are dealing with and relate it to the deaths, and therefore help us to prevent deaths from the disease.
Thank you, Dr. Masi. And the next question is on travel restrictions. The person would like to know.
Christine, may
yes,
I
Patricia.
add something?
Oh, yes, please do.
There are some people in our chat who are also contributing to the conversation, and we thank you very much. We have Emmanuel Mugisha, who responded to Dr. Muhwezi's question. And he's saying, yes, someone asymptomatic today can turn symptomatic tomorrow. Mugisha is also saying that unlike HIV, where one cannot be cured, our bodies can get cured of COVID-19. Indeed, everyone who has been discharged from hospital has been tested and confirmed that he or she is COVID-19 negative. Please, Mr. Mugisha, confirm to us if you are a medical doctor, because today we wanted AfS Live, we want to hear from medical doctors. The myths are so many, we've been overwhelmed. So the only truth that we are going to allow today is from medical doctors or people in the field of medicine or research. Just please confirm, say, yay, I'm a medical doctor. So Christine, you can go on.
Thank you, Patricia. One last question from Dennis. It's on travel restrictions. He's asking, how effective are travel restrictions and quarantines? Has there been any documented evidence on this? Dr. Masi or Dr. Winston?
If I can say something about this, all these different measures that were taken or have been undertaken to manage COVID are important, are important, but there is where they stop and there is where they can go. Certainly, travel restrictions or lockdown, as we came to know it, where the countries were put under severe limited transport and movement, have got their place, and they played a very important role. For example, in Uganda, I know that the lockdown and travel restrictions happened even before we had the first case. And the whole essence at that stage was to try and prevent, hold the disease at bay, let it not come, because we had known, the country had known that more of these COVID-19 cases would enter the country through importation. That is coming along with people who were traveling in the country. And that served the purpose up to a certain point, so that we are trying to prevent. And the prevention was basically for the purposes of trying to prepare the healthcare system. I think one of the things we need to remember is that when you put all these restrictions and whatever, our healthcare system, especially in much of Africa, is not very strong. And therefore, it was very, very important to prepare the healthcare system in terms of equipment, in terms of personnel, in terms of medication, supportive medication, in terms of capacity building, so that they are ready when people start becoming positive, they would be managed in this healthcare system. So that was very important to restrict, keep the enemy at bay, and prepare the system. Then certainly we know that in many countries, including Uganda inclusive, these restrictions and lockdowns were lifted, and people were given incrementally. Some sections are still locked down, but incrementally a number of sectors have been allowed to operate. This has come with its own risks, but it was important to lift, because people, you may prevent COVID-related complications, but people get into trouble with the other social issues that arise and economic issues of poverty and all that kind of stuff. So now that the restrictions are lifted, then we are into the phase of trying to delay the impact. But that also has a phase, and then we go into the phase, I think like in Kampala in Uganda now, we are at the phase of managing, trying to manage, because we are seeing a spike into this COVID-19. I will be giving you the statistics when I get time. But yeah, to say, did travel restrictions and lockdowns have a role to play? I would say yes. They had a purpose, and I think they served that purpose.
Thank you, Dr. Muhwezi. The next question from Verenado leads us also to the issue of easing of lockdowns by African governments. He says countries like Tanzania have used different approach, especially on the use of face masks and keeping social distances. This has spilled over in Kenya, with some asking the Kenyan president to go by this approach. What is the danger of this approach? And before you answer this, Dr. Mercy, I also would like you to respond. After you answer that, I think Dr. Winston should also respond to, did we lock down too early? Or did we ease the lockdown too early as well? It's a catch-22 of sorts. So Dr. Mercy, over to you.
So the
use of face masks, yeah.
Yeah, the Tanzanian approach is still baffling. And the unfortunate thing is that we don't have a lot of information and data coming from our neighbor at the south. But what we are seeing, and really what it all boils down to, is that the coronavirus infection is really a personal responsibility. If you think about hand washing, the government shouldn't tell you that you need to wash your hands as often as possible or to sanitize. If you think about wearing a mask, yes, the policy guideline is given, but the actual wearing of the mask boils down to the individual. So if you look at it on the grand scheme of things, the responsibility rests with us as individuals. So yes, could be the Tanzanian government, we don't have a lot of information there, but no one is stopped from washing your hands, really. It is one of the ways that has been proven to prevent communicable infections. If you think about even diarrheal diseases, the other flus and common cold that we are talking about, hand washing is actually a key component in disease prevention. So Darren, you don't really need the government to tell you much about it. So yes, there are dangers to it, because at the very beginning, we did not really know what we were dealing with. But now we sort of have an idea. Now we have our own data as countries, East African countries, our own data as African countries, that can be used to inform policy guidelines, to inform policy direction, because now we have our own data. We are seeing the demographics, we are seeing people with pre-existing conditions. So we are able to make our own decisions on this. And allow me to just touch on the issue of lockdown. Did we lock down too early, or did we close our borders too early? Did we open them too early or too late? I think this virus was a matter of when it will come into the country, not if. And one of the ways of delaying that was making sure that you have closed your borders so that you put your acts together. I mean, if you know there's a storm coming towards your house, will you leave your windows and doors open? You will close them. You'll probably put some shields so that they don't come and blow off your house. So the closing borders allowed countries to organize, to strategize, and know what to do at what particular time. Now, once you have known that, once you have educated your people, once people understand, or have a little bit of understanding of what is happening, then you found that countries now are at a point where you have to make a delicate balance between livelihoods and lives. The economy was suffering on one point, but people's lives were also at stake at some other point. So now this is where governments were making that delicate balance of, what do we do now? Livelihoods are here, and people are saying, this coronavirus, which I haven't seen or haven't gotten infected with, might not get me, but I may actually die of hunger. So you found that people now were getting into that point where you have to make that delicate balance. But it's been a fluid situation. What we did in March is not necessarily what we'll do now. What we are doing now in August is not necessarily what we'll do in December, because it's changing, and we are changing depending on the information that is coming out, on the scientific studies and research that is coming out concerning this particular pandemic.
Thank you very much, Dr. Masi. One other question is, what lessons or what advice should other governments consider before lifting lockdowns? Those that are still under lockdown, what should they consider before they lift lockdowns in their country?
For me, and Dr. Muhwezi will add on to this, for me, at this point, we are looking at what I said, lives versus livelihoods. If, for example, your healthcare systems are in such a place where they can attend to people who are critically ill or people with severe disease, then you can open up, because it means if people need oxygen, if people need critical care, then your health systems are able to attend to that. And it would not matter if somebody is in northern Uganda or is in Kampala, or if somebody is in Nairobi or is in, northern Kenya, that all of us have a chance at accessing healthcare services at that critical point. Then for me, that will be a point where you can say, now you can open up, or you can now live freely as before. But obviously, these preventive measures and precautions will still be applied, because prevention, as we say, is better than cure. And at the end of it, prevention is cheaper than the treatment of COVID-19. In Kenya, for example, per day of ICU care would cost at least $700. If you look at the kind of people that we have in African continent, who can afford $700 in a day? But if prevention is just costing you a mask, a fabric mask, which you can buy off $2 and you have it for a longer time, then that will be cheaper. So that's one. The other bit is that we know that strengthening our healthcare systems takes time. We may not achieve this in the short term, but measures can be put in place such that we are able to incrementally improve and make sure that in the next 6 months, 1 year, then our healthcare system to some extent can respond to critical care. Because what COVID-19 has presented us as the African continent is a chance to work on our healthcare system. If there was an opportunity to work on universal healthcare coverage, then this is an opportunity for us as African countries. Unfortunately, what we know we should do is not what we are doing, and that's a whole conversation for another day. But this is the chance to make sure that the citizen, the everyday citizen in any part of the African continent, has a chance at accessing quality healthcare services when they need it.
Very well spoken there, Dr. Mercy. And now, Dr. Muhwezi, Africans as a people, we are very social and we live in communities. We love to shake hands, we love to hug, greet, and we live in large families. Do you see these traditions dying away in the event that COVID-19 does not go away? Will this become our new normal? No shaking hands, no viewing of the dead, no hugging, no living in large families. How will this affect our traditions as a people?
Yeah, thank you very much for that question. But before I touch on it, just to extend a bit what Mercy has just talked about, that this lockdown was a very good strategy. It was raised and everybody was happy. But the challenge we have is that it was raised and people took it in, that they are free, and people threw away, in many of African settings, threw away the guidelines that were being talked about day in, day out as the lockdown is opened up. And that's very problematic. And I think the government, which is in charge of the country and therefore public health, still has on its chest the mandate or the last card of imposing either another lockdown, total lockdown, or localized lockdown, depending on what is pertaining. If I can tell you some facts, for example, the tests that were done yesterday in Uganda shows that they picked 54 people who were positive in Kampala alone. And that means so many are in the community. Our death rate has risen to 19. That shows a very worrying picture. And so lockdowns could be imposed or could be brought back and slapped at businesses or small localities or districts or regions, depending on the picture. So it's not off the cards yet, and people should not celebrate. Instead, what our people should do is to, as much as possible, adhere to the prevention guidelines that the ministries of health have provided. Now, from that, what you've asked me about our long-cherished cultures of hugging and shaking hands and living in large families, you know, these long-cherished and culturally entrenched practices, hugging, shaking hands, you know, large families, is a fact of life. That's how African societies are structured, and we like it. But the dying process of these very well good cherished processes will be slow but sure. It may happen. Let me tell you, culture changes, and culture is very dynamic. Our practices change, and the change, you know, change is a fact of life. And if you resist change, change can change you. That's what I remember when I was still a young man and what we studied. So we know that this change is a fact of life. So besides, culture has never been in a state of equilibrium. It's dynamic. The things that we were told not to do when we were dealing with HIV/AIDS scourge in the early days, and people thought they were impossible, they have adopted and people have changed appropriately. We also know that culture changes because of contact with other people, either through diffusion or acculturation. People will change, picking new behaviors, new traits. Technology will impose changes. We now see use of mobile phone technology, which has penetrated far deep. Internet is here with us, means of transport. So in other words, what am I saying? I'm really saying that these traits, the way we love them, in this generation, another generation ahead, we don't know what the situation will be, but I think there will be changes, especially if we are going to live with COVID because we don't have treatment for it. It's still going to infect people. It's still going to threaten the lives of our vulnerable populations, the elderly, the sick. It's going to be a threat to our health workers. They can be super spreaders if they contract it. So we'll have to change. And recently when I traveled up country and my parents are still there, they told me, oh, you are from Kampala. How are you? Welcome home. But I didn't touch them. They are very conscious. These old people are very conscious. So you see, it has already started, and let's not fuss about it. These practices will change because existential threats are what brings about changes in culture and practices. Thank you.
Thank you, Dr. Muhwezi. One more last question to Dr. Mercy from Miriam Mutenyo. She says, in Uganda, we are now experiencing a lot of community transmissions with a steep epi curve, and yet complacency in the use of, in following the guidelines developed especially by PPE is such a challenge. How is Kenya dealing with the issue of complacency in communities, in aiding of controlling incidences in community transmissions? That's to you, Dr. Mercy.
So what we have done in Kenya, what I see happening a lot is a lot of community sensitization when it comes to what I talked about, personal responsibility to be able to do a mask, to wash your hands and sanitize and keep physical distance. Those are things that, you know, communities can do. We still have challenges, definitely, when it comes to personal protective equipment for our healthcare personnel, where they're inadequate, they're in shortage. Sometimes they have to reuse things like masks because of the shortage and the problems that we are in. And at some point, we had global supply chain challenges. So, as I said, it's an ongoing process. It's an ongoing pandemic. We are still here, still trying to find ways of learning and trying to find ways of coping. But a lot about communities is just sensitizing them. And one of the effective ways that I've seen work, at least in one of the counties, is using community leaders and community leaders, religious leaders to talk to people about the coronavirus, because these are people who in the communities that they are in have a voice that is respected. So when these people engage their communities, then you find that those areas in terms of adhering to the preventive measures is better. You find less complacency as opposed to where they just rely on mass media.
Thank you very much, Dr. Muhwezi and Dr. Mercy. Patricia, I see our time is fast spent. Do you want to comment?
Yes, just a moment. Our time is fast spent, true, but this conversation is exciting, and we can give ourselves an extra 10-20 minutes. But I would also like to hear Dr. Muhwezi on the issue that Dr. Mercy has just addressed, the issue of complacency, since he comes from behavioral science and he's working with communities. Maybe he can tell us how, on top of what Mercy has said, how else can we deal with complacency? Because it's not just in Uganda, it's also in my community here in Ibadan, Nigeria. I'm sure it's in all African countries. We've seen it in the US, people disregarding what they're being told, they go out and protest. You know, how do you, the experts, help us to remain aware of this, that COVID-19 is real and it's actually killing people?
Thank you very much. Now, I think the bottom line is that we need to appreciate that behavior change may take time. Also that it's natural for people to resist any interventions, any proposals that are going to drastically alter their way of life, the way of life they have been used to. That's natural. So for anybody who is involved or who is into the enterprise of behavior change, you know that it takes time. You have to be patient. You can't afford to be frustrated that people are not picking up very fast what you are talking about. Because it boils down to individual perception of risk and threat appraisal. As long as people have not come to appraise that their lives are in danger, to perceive that their lives are in danger, and therefore see the danger at their footsteps, in their face, then you have a problem of compliance. Does that mean that for us who are communicating, we are not communicating enough? Not at all. It's about human nature. Human nature, people tend to be comfortable in certain zones, and to shift even a little bit takes a lot of explanation, takes a lot of experiential learnings. At times they say, if you want to stop a child from touching a burning candle, you just let the child touch the fire bit, feel the heat. As we go on, certainly I think it's very important that we'll keep communicating, we'll keep putting the danger in front before our people, our communities. Ultimately, slowly but surely, change will come. It will come at a cost, because some people, out of refusal, out of having alternative explanation to what is happening, may unfortunately be consumed in this denial. But the denial will not stop the fact that the disease is around and it's going to kill people. So I think the bottom line is patience, is consistency in messaging, but also getting the people to communicate to these communities. I, Professor Muhwezi, cannot communicate to the entire Ugandan community effectively, because there is a community I appeal to, but there is a community which may take me as a joker. So we have to get role models of different communities. If you are going to talk up to people who live in slums or street kids, then you need a role model for that community. If you are going to talk to the royals, then you need royalty to talk and speak to that group. If you are going to talk to commercial sex workers, then you need a model of that population. In other words, the enterprise of looking for different role models for different communities and different subgroups in community to be the ones to help us pass on the message is very, very important, and will help us win this battle. Otherwise, I am not one of those who is frustrated seeing what we are seeing, because I know that behavior change takes time. I know that perception of risk takes time. I know that there are other existential threats that people face, and compared to COVID, they would think, well, at least I've eaten. COVID, let it take care of itself. So we know all these alternative explanations in our environment, but we cannot get our feet off the pedal. We know that slowly by slowly, we will get to win the battle. Unfortunately, it will be at a cost, because we are opening, by being defiant, we open our healthcare infrastructure to threats, to danger, but we also open this danger to vulnerable populations who incidentally are much more likely to succumb to COVID-19. So the young people should really help. Thank you very much. Thank you very much.
Thank you very much, Dr. Muhwezi. And like Parisha would agree with me that this has been a very interesting conversation, but time is against us. There are still more comments and questions on the chat, and I'll ask the people that are with us right now that the conversation will continue on our social media platforms. This webinar was brought to you by the Alliance for Science, a science communication platform. Be sure to join us, become members by joining the website, Alliance for Science, and also follow us on Facebook. I'd like to have one last comment from Dr. Mercy and also Dr. Muhwezi before we wrap this.
So allow me to correct something. I know here on chat, my name is appearing as Okiror, but so I'm Dr. Mercy Korir. I'm the lead group editor at Standard Media Group, not Nation Media Group. So I'm at Standard Media Group based in Nairobi, Kenya. And I'm the group editor for health and science for the media group. So I deal with both TV, radio, print, and our digital platforms that handle and do health and science stories. So my closing comments really are that we are all responsible for our health first. And with this COVID-19 pandemic, it has also shown that your neighbor's behavior directly affects you. Your person that you're working with, their behavior directly affects you. So if all of us do what we had needed to do, then there'll be a collective protective measure for all of us. So that if all of us are washing our hands, then we've minimized contamination. That's one. The second one that I keep telling my fellow Kenyans is that the virus does not move. It is people who move. The virus requires a host, then it propagates in that host. So if you move, then you will have, moved the virus to another location. So the staying put really works. If only move if you need to move, and think about moving and traveling as a matter of life and death. So I think I would like to leave it at that.
Thank you very much, Dr. Mercy. Over to you, Dr. Muhwezi.
Yeah, my last word really is more or less reiterating what Mercy has just talked about. Please, I want to encourage all our listeners and participants that please make sure that you keep adequate or recommended social/physical distance from your colleagues. You try as much as possible. Actually, don't try, do it. Wear your masks consistently and correctly at all. Use it putting on condoms and preventing HIV. I mean, this is a mask. Please wear your mask correctly and consistently. Wash your hands regularly or sanitize if you can get a sanitizer. Avoid touching your soft parts, your mouth, your nose, your eyes. Please, that's why you wear a mask to avoid those touches. And you don't have to move at all times in the places you don't have to. Only move out of your home when it's absolutely necessary. Otherwise, stay home, stay safe, and all will be well. Thank you very much.
Thank you very much, Dr. Muhwezi. Patricia and I are very happy to have had you as guests on today's discussion. We also would like to thank all our viewers online, via Facebook and also on Zoom. Thank you very much for tuning in today. Tune in again next Thursday, same time, with another interesting topic for discussion under the Alliance for Science. Otherwise, stay safe, wear your masks, wash your hands, and keep social distancing. Thank you.